Hi everyone, thank you for joining today. Hi David, hi Lucy,
Hi.
hi Michael.
Yes, good morning, Joel.
Good morning, Michael. Hi everyone, thank you so much for joining today. Today's session will be a TBPPM Friday Forum on why and how we should address mental health for people affected by TB. To introduce the session and the moderator and the panelists, I'm happy to invite my dear colleague Namrata Rana. Namrata is a research assistant at the McGill University Health Center, a master's thesis focused on mental health interventions provided for TB. And she is the brain behind today's session and a wonderful colleague who has helped the TBPPM Learning Network as well. So over to you, Namrata.
Thank you so much, Joel. So good morning. I hope everybody can hear me clearly. Welcome to the TBPPM Friday Forum. And so, like Joel mentioned, today we're going to be talking about the intersectionality between TB and mental health. This week on October 10th was Mental Health Day. So in solidarity with all the people affected by TB, we wanted to highlight this topic and kind of shine light on the psychosocial aspects related to overcoming and facing the challenges due to TB. So we're really excited because we have a fantastic panel of speakers and a fantastic moderator as well. So I'm just going to quickly introduce everyone, and then we can get started. So we have Dr. Azimathal. She's a psychiatrist who has a big concern in mental health of TB patients. And she has also currently helped us develop the DRTB operational guidelines. So welcome, Dr. Azimathal. We also, yeah. Sorry. So we also have Ms. Ashna. She's a lawyer and a public health professional, and she's also a MDR-TB survivor, and she's currently associated with the Survivors Against TB, which is a community group that works with TB survivors and has a diverse stakeholders that advocate for patients and a community-focused paradigms. So welcome, Ashna. We also have Anita. Anita is a Fulbright scholar with a graduate degree and from the Masters of Arts program in the Social Sciences from the University of Chicago. I actually read your paper, Anita, so that kind of helped inspire some of the Friday Forum components. And she's a development professional with over 15 years of programmatic and research experience working in the developmental sector in Pakistan in the areas of sexual and reproductive health, and especially in mental health. We also have Prachi. So Prachi is a health economist and health sector project planning and partnerships expert. She has 17 years of work experience leading and managing a lot of these large-scale health sector programs that is focused on improving affordable healthcare services and working with governments and different developmental agencies in order to address these needs on a large scale. We have Shailja. She's a graduate in dentistry, and she did a year-long clinical practice. She's immersed in public health, and she's also been a recipient of several great awards and has significant experience in project management research and contributing to the TB Reach Wave 9 implementation across 3 districts at the Innovators in Health. And lastly, we have our moderator, Chapel. Hi, Chapel. He's an independent advocate, public health specialist, and commentator. He's also the head of PI Consulting, which is an organization that works on issues of health, development, and human rights. So I'm going to hand the microphone over to Chapel to moderate this forum.
Thank you, Namrata, and welcome everyone. I'm really happy to be moderating this panel because I'm also associated with an organization called Survivors Against TB in India, of which Ashna is also a part. And for the last several years, over a decade now, that we've worked with TB-affected communities, the issue that has come and re-emerged in our discussions, in our understanding of their lived experiences, and of course, as part of TB care, is the issue of mental health, which doesn't get addressed. Part of this is, of course, a primarily clinical paradigm in care, where we see quality of care being defined primarily by diagnosis, treatment, cure. Unfortunately, not too many paradigms in TB care focus on issues of stigma, mental health, the well-being of individuals during treatment, but also post-treatment. Because when we talk of TB and mental health, I think it's very important to understand the mental health interactions, but also the mental health implications of TB and the interactions that continue well beyond cure. In fact, the earliest work that we did on mental health and TB emerged from our work from stigma. And this led to a whole lot of realizations that you could not provide high quality care or even compassionate care or empathetic care to TB affected individuals and communities or even families without front and center addressing the issue of mental health, both for TB affected individuals, but also their caregivers. Now, a part of this paradigm that we're going to be having in this discussion today and the numerous issues that I hope will emerge will highlight both the lived experiences, but also the health system implications, because whenever we advocate for mental health issues amongst TB programs and TB affected communities, one of the things that that emerges is that the system is not prepared, the system is not equipped, the system is not oriented towards providing mental health services or mental health support. I don't even want to stretch it as far as services, because that would open a whole new paradigm and requirement that current health systems, especially in low and middle income countries, are less than optimized to provide. The question of mental health is also inextricably not just linked to people who are affected, but also to their genders, also to their economic status, also to their social status, and of course, to life as it goes forward in TB. With this short introduction, I actually want to give more and more time for discussion. So the way we want to do this is that if you have, we will be going through the panel with a set of questions that we think the panelists will respond to, but also if any of the audience have a question, please type it in the chat box. We will try and pick up that question if we have time. Hopefully we will, because we hope this will be a more interactive discussion, which highlights both lived experiences, but also the challenges that arise from various perspectives. So with that, let me actually come to two of the people who have been affected by TB on this panel, because I think we should start with understanding what the perspective of those who have survived TB is. And while it may be a no-brainer for many of us who work in the field that mental health is critical, I think we really need to understand from the perspective of those that have been affected by it, what does it really mean? So let me turn to Ashna first, who is also a colleague. And Ashna, I want you to pick up on this question because we've had these discussions multiple times. And We've articulated this multiple times to national programs, but I want to hear from you and then from Stephen, hopefully, that why is mental health an important area to address when we're talking about TB? I mean, I particularly want you to refer to your journey, your TB journey, and why mental health mattered to you during that time. If you could give us a short answer and give us an idea, touch upon your experiences, that would be very helpful.
Sure. Thank you so much, Apple. And thank you for having me here. So just very quickly, to the first part of your question about why mental health is important to address, there's increasing evidence now that there is a bidirectional relationship between mental health and TB, where persons with mental health issues, they may often be forced to live in housing conditions that aren't really conducive, well ventilated. Access to income may be an issue because holding down a job becomes difficult in the absence of mental health support, or environments that aren't ableist but inclusive of persons with disabilities, whether neurodivergent or otherwise. So all of these factors kind of also become risk factors for infections, including TB. So overall health tends to suffer. The other part is with TB, the diagnosis itself and the length of the treatment. I mean, with COVID, we saw 2 weeks of treatment, and people were just like, the isolation, oh my god. With TB, with sensitive TB, it's 6 months, and with drug resistant TB, it's at least a minimum of 2 years, and it can go on even further. So to be on a treatment for that long, and these are mostly toxic drugs that are available in countries like India, they're not, the newer drugs aren't easily accessible. That fatigue, the physical fatigue, the emotional fatigue of it, the stigma attached to TB, and the added side effects of some of the TB medications, which do have which do affect mental health. They're correlated with anxiety, depression, suicidal tendencies. So all of this tends to have quite a catastrophic impact on the patient's mental health. And so addressing that mental health becomes critical, first and foremost from a quality of life perspective, because the treatment isn't supposed to, it's supposed to basically improve my quality of living at the end of the day, towards the end. The second also is because it's that much easier then for me to actually complete treatment. And so even from a public health imperative where you're looking at whether it's containment or elimination, this becomes that much more critical at that level. My personal experience, of course, for me, other than some of the physical side effects, one of the most pronounced side effects was mental health conditions, because I'm predisposed in a sense. So my depressive tendencies were exacerbated by cycloserine to the point where I was having intense depressive episodes, and there was a point where I was contemplating suicide. And the only reason that I could manage the way I could manage was, I had the privilege and the means and the awareness around this because I was working in public health and mental health even before I got TB. But also because my doctor was really supportive. So one of the things that I remember when I called him after my breakdown, and I thought I was making sense, but I was just literally crying on call. And he told me to stop my medication for 4 days. He's like, we're going to stop for 4 days and then we're going to introduce it again. And I'm like, no, but we can't stop it. We have to continue. And he said, you're not happy. And that struck me as the weirdest thing to say. I'm like, who stops medication for that? He's like, this is not the quality of life I want for you. We're giving you treatment so you can live a better life. So we're going to pause under medical supervision, and then we're going to resume under medical supervision. And those 4 days honestly made all the difference. I felt like a 3-ton truck had been lifted off my head, and I could then actually complete my treatment properly because I got that break. He waited till it was advisable. He didn't do it at the first. I think this was like almost a year and a little more into my treatment that he finally took this call. But that was one man. The system isn't that supportive. I just got lucky with the doctor I had. And when I looked for support, that's how I found Survivors Against TB. So one of the survivors, Saurabh Rani, actually spoke to me at length. He introduced me to Chapal, and we wrote a piece together of a scroll, I remember that time. And that's how I got into it. But I was, despite all the suffering, very, very lucky and incredibly privileged. And it made me shudder to think what happens when people don't have that privilege, because even with it, I had to go through all of this. So, yeah, I'm going to stop.
That's very, very helpful. Stephen, what about your experiences? why do you think it's so important for you? And what did your experiences tell you?
Yeah, thank you very much, Apal. Good morning, good afternoon, good evening, colleagues. My name is Stephen Anguva. I coordinate TB champions in Kenya. And when you talk about mental health when it comes to TB, first, TB is a journey. It's like when you board a flight, always there is a flight attendant who announces that now you're starting a journey, and this journey, these are the things, that conditions and so on. And they tell you to listen to them even if you are a regular traveler. So they warn you in advance. But when it comes to TB, we just focus on treatment side of it. And we forget that for treatment to be successful, you have to deal with the person first before you deal with the disease in the body of the person. So people come with a lot of baggage in their lives. And then we add in another baggage that is called TB treatment. So a mental health assessment and a mental health management is very critical when it comes to TB because one, as my colleague Ashna said, treatment is going to take long. This is a person that has not been on a long-time treatment. This is a person that is now getting that new information about his or her health. And then the other thing is about living condition has to change because we tell them spend most of the time in an opening. If you are used to taking alcohol, smoking, you have to change your lifestyle. So once you talk about lifestyle changing, you have affected the mental ability of this person. You've already talked about emotions of this person. These are persons that will develop side effects. It's a new agent that has come into the body. Treatment is a new agent that has come into the body. That means that with TB treatment, there are some side effects that will come along. And each side effect presents differently. For example, when people take drugs like rifampicin, you will notice that the urine changes. If this person is a man, men usually go to urinate at a communal place whereby they are all standing there. So somebody is scared because I want to urinate, but my urine is not going to be the same like the others. So already stigma has come in, and that stigma brings in the component of mental problem. So it's very important to address the mental health because one, treatment is a journey. Two, this is a new agent that is coming in the body. And three is about because of social. The person has to change their lifestyle in terms of social. They have to understand that adherence, for anybody to adhere to treatment, they need that social support. And social support, mental health is one of the social support. And every now and then, we need to be talking about mental health. It's not about a one-time thing that when somebody starts treatment, they talk about mental health, but it's supposed to be like a package of care. Every time I come for my clinic, I'm supposed to be told that how are you doing? How is your family? How is your health? We don't only talk about, do you take your medicine? So it's about having mental health as a program that should be integrated into TB care and services so that it is a complete package. Without mental health, the package is not complete because with TB, lifestyle has to change, everything has to change. Even education system has to change because you have to come for clinic. It's not about just taking medication. So mental health is very critical and very important when it comes to TB. So it's very important for us to talk about mental health and have it as part of the treatment care and package for TB.
Thank you, Stephen. I think both Ashna and Stephen made some very, very important points, both at an individual and a community level, but also at a health system level, because the thing about education changing is so critical because so many doctors that I have worked with say, we're not prepared. The system has not tasked us. We don't know how to give mental health support. We're discouraged from asking patients all the time, how are you doing? Because that could start a whole different conversation that we don't want to have. And that's also very important. Turning to the health system level, we have three great implementers here, and I want to turn to each of you and ask this question, because this is still something that we are grappling with in low and middle income countries. Let me start with Anita. Anita, what according to you are some of the ways in which mental health comorbidities are addressed in TB across the care cascade? Are there examples that we can learn from that you have studied and looked at? And if you could talk about them a little bit.
Sure, Chapal, thank you so much. So what we've done here at IRD Pakistan is that we are using a task shifting model to integrate mental health within our TB program. So what that means is that we have a lay counseling model where we train people who are community-based lay counselors. We train them in basic counseling skills so that they're able to provide first-line therapy for mild to moderate depression and anxiety. And then what we ask them to do is whenever a TB patient comes in and they are told of their diagnosis, they are sent to the counselor who is able to, as Ashna and Stephen have emphasized, are able to sort of just do a basic screening for mental health. At this point, usually we find anxiety levels are very high because people have been ill for a while and they've just got a diagnosis. But also if depression is underlying, that tends to get exacerbated, or just learning about the diagnosis can be really triggering. And so what we ask the counselor to do is then take them through 4 to 6 counseling sessions. Just again, basic counseling skills, listen to them, hear them. The counselors are also trained on the TB medication and what potential side effects can be. So they're able to also counsel in that regard. So a patient knows what to expect as they embark on this journey, as Stephen said. And then they're also trained in knowing when somebody has moderate or severe mental health, then they need to refer them immediately to a psychologist, which we have on our team as well. And what we have found is that, so we've been doing this since 2014. We did a study in 2017 with 3,500 TB patients, which was an RCT. And so we found that for those patients who actually had the mental health intervention, their TB treatment completion rate was 93%. And for that group that did not have the mental health intervention, the TB treatment outcome completion rate was 71%. And so we found that it really has a very tangible and measurable impact on TB treatment outcomes. But even from all the qualitative feedback we have received from TB patients on quality of life, anecdotal evidence, all of which just says that we're so glad that there was somebody to talk to us, to explain it to us in non-clinical terms, explain to us what is happening here, even explain to the families as well. And so we have published on the way in which this task shifting model is actually, it's not as resource intensive because you're using community-based counselors. Wherever there are no resources, we ask to train existing healthcare providers. So, Chapal, as you said, doctors often don't know how, but they also don't have the time to sit and do a 45-minute counseling session with somebody. So it's helpful to have somebody in the care pathway who can actually take out that time and actually invest themselves into the patient. The last thing I want to say is sometimes we find when TB patients are really ill and are unable to come in for their physical health checkup as well, we do phone counseling with them. So we've established rapport in the first 2 sessions when they've come in, but then we're able to continue those weekly basis on call while they're at home, which has been really, really helpful.
Thank you, Anita. That's a very, very helpful example to highlight. Prachi, I want to turn to you because you have done something similar and you have been doing this in Gujarat, and I wanted you to share your experiences as well around this.
Yeah, so we, Chapal, it's very similar experience that what we are doing in our TB program, that we are more focused on the community part. So it's more of a community model that we have established, especially when we're talking now about patient-centered program. And in our program, what we have found that you cannot really, despite of we being in the development sector and being supported by donors and funders, whether it's government or bilateral donors, at one point of time, you will have to transition the project to the government or the public sector. So you will have to, right from day one, you will have to think about sustainability, scalability, and then have an integrated model. So what we did was we did keep resources on ground, which are the field officers, which are very well a part of the community or the neighborhood, and they are trained on screening these TB patients on mental health tool, or what we were using was the patient health questionnaire, PHQ-4, to identify anxiety and depression, and followed by counseling sessions. But we also realized very early on in the program that a lot of times, even if these patients who are being treated for TB, there is so much of stigma, not just for TB, but also for mental health there, that they really don't feel comfortable initially, even if you're counseling them in the facility or coming to their family or to their homes. So what we did was we established a call center, and call center was not just for this one project. So we use a lot of technology, and this is a control center, as we call, which has trained counselors, and these are all either clinical psychologists or just freshers out of college, which have completed their science graduation, all of that. They have been trained under psychiatrists and clinical psychologists. They are the ones who are at the back end, and currently they are in the capital city of New Delhi, but they are providing services across many states, and not just handling mental health for TB, but they are also handling mental health for various other chronic illnesses. So this is something that I very strongly feel that, especially when we are talking here today about TB, that, and if you look at the cascade of care, so initially when a person is diagnosed as TB positive, that time the anxiety or depression or mental health issues are at the peak. So we saw that there were around 93% of such patients were suffering from mental health issues during initiation of treatment. But as it came down and towards the end of the treatment, it came down pretty kind of sharply. It came down to less than 10-12%. Is how it turned around to be in our project area across these districts. And definitely, I think that since we are talking about reaching to a lot of people, and especially who are living in rural, hard to reach areas, we definitely, and the need of our is today to use a lot of these digital technologies which are available, and not just the digital technology for 1 to 4 counseling sessions, but obviously we need to follow up with these patients. So we also, on a random basis, we also selected a few patients and visited them to see how they are performing. Then we also established linkages with the premier institutes for timely referral, because majority of the TB patients, if you see, more than 80% of the TB patients will be in the mild category, wherever you go. The rest would be in the moderate or very severe category, where you would need to refer them to an inpatient facility. And what we also did beautifully, that we did realize that a lot of these patients were very, very poor. So, and they were the only people who were the bread earners of their family, and because they contracted this disease, they were thrown out of jobs and they did not have any work. So they were living in very dire conditions. What we also facilitated for them along with this was the social security schemes, which are already existing in the government. But there's no awareness. Obviously, unlocking these schemes, government scheme, is also in itself a very time-taking effort. But we thought that let us do this, and we also saw a lot of improvement once the money started coming in. So money, however, very small, but it did really help kind of elevate their mental. It gave a boost to their mental health, and the psychosocial supports, I think, is very, very important, apart from whatever counseling and treatment facilities that we try and link them up. So that is how we did. And there are a lot of research currently going on, and I think the paper should be out very soon on this.
Well, we're looking forward to it. Shailja, if I can turn to you, and if you could briefly share your perspective on this, if there are any examples that you've come through in your work.
Sure, thank you so much. The only thing which I want to highlight is we work in a first user sector. And here, when the first question when it was like, how the mental comorbidity has been addressed here in care cascade, it's not addressed in the system itself. So we at IIT work very closely with the system, and there is like a large loophole in the system where there are a lot of things which are going. So not going in depth, what we tried to fill in the gap was we build paradigm of the approach is always biomedical. So we try to, revisit the approach, how we can be psychosocial approach. So in that model, what we are trying to address is how they are, how the treatment has been adhered to, how the psychological issues are being addressed, and relating it with the socioeconomic factors for the patient. So our model is also similar to what Anita and Prati has shared. We also have a pool of counselors. They are also day counselors, where they are being trained in the counseling. We do screen person with tuberculosis and person with DRT. With the screening to which is SRG, self-reporting questionnaire by WHO. Once they are identified with the need of psychosocial, like their psychosocial need has been identified, they are like provided basic counseling. If they require professional counseling, they are linked. We just don't only stop our service at counseling. What we also do is we do a need assessment. So a need assessment has been done to identify what are the underlying causes apart from the treatment where a person is requiring a support for. For example, they are telling they have a lot of issues. So we work in a quite rural setup, and that's in Bihar, which has the highest migrant population all over the country. So you'll find every fourth or third patient, from going and coming somewhere from the other state. So working with that vulnerable community and also the marginalized community, they have many concerns revolving around. So we try to link them. We link them with the schemes. We also provide them the livelihood support somewhere, and also try to address their needs. What we also do is we undertake family in counseling. So we don't only counsel the patient somewhere, we also involve families and also try to make a very conducive environment where they can share their issues. Major issues which we identify is on the gender part. Here, it's a very strong patriarchal setup. So if a female is being said I am having tuberculosis, first so she will hide from her in-laws. And if their in-laws comes to know she's been abandoned by her husband, she has to stay her maternal house, and so a lot of stigma is also present. So handling that situation really becomes tricky for us, because we also have to take for her, and many are married at younger age and getting pregnant, so she has a kid around her. So we try to provide the support with the counseling to the in-laws also, and taking in that consideration, it's completely fine. So that is the thing which we are working on. With the professional help which is required, we also refer patients and provide them support to psychiatric consultations if they are required any. So yeah.
Thank you. All these examples are very helpful, but I also want to turn to the broader issue of understanding how we put the affected individual at the center, and how we make the system work for them. Because we all know through our work that TB is not just a medical malaise. If it were just a clinical disease, it would be so much easier to handle. Unfortunately, it has so many layers that the health system is not equipped to deal with. In India, for instance, we've seen the rollout of support schemes, stigma mitigation, a gender responsive paradigm. Yet on the ground, things take longer. And what is even more difficult is the fact that a large section of populations in low and middle income countries go to the private sector. Now, you have very little say in the private sector in the quality of care. And while guidelines are issued and trainings are done, the issue of mental health is even less paid attention to, primarily because the private sector in particular optimizes the time of the health provider and healthcare workers. So I want to turn to the issue of how can we provide, take these examples, take them to scale, but also think about how do you provide effective mental health support in both the public but also the private sector. So I'm going to start with Ashna and Stephen here. If very briefly, you could give us 1 or 2 points on how you think that can be done. And then I'm going to turn to the program implementers who can talk about it at a systemic level and also at a policy level.
So I think in the public sector, one thing that can be done is integrated, coordinated care. So starting from the primary healthcare level, where you can have community-based organizations or community workers coming in and doing the primary screening and referrals or interventions as needed, as the case may be. It also requires a certain level of awareness and destigmatizing, because while again it's a demand supply thing, so that push pull has to be there, because you may provide all the things that you need there, but if you haven't addressed the social barriers or the cultural barriers to accessing mental health services and even TB services to begin with, mental health is like an added layer on that. So that won't really work. So it has to be the demand side and supply side being taken care of when you're looking at addressing mental health care. In the private sector, I think one way that we can look at it is with notifications, right? The incentivization did sort of, at least in India, from the data that we have, improve notifications over a period of time. So maybe incentivizing offering mental health support as part of TB care in the private sector is one way to look at it. But when you're looking at it from the sort of the affected person's point of view, before any of this happens, the mindset shift that needs to happen is very often when we talk about community engagement or person-centered care, we talk about telling people what they need or training the community. I think it's time we start inverting this to social listening, where we actually listen to survivors and patients and the community about what the challenges are, what the unique barriers are, how do they differ across gender, class, age, caste, religion, disability, sexual orientation, and then look at what kind of interventions we can put in, because it can't be a one size fits all approach. It has to be an intervention that caters to diverse health needs and diverse demographics. So yeah, thank you.
I'll take it up from where Ashna has left. I think what we need to do first is we have every day people are getting cured from tuberculosis and new people are being diagnosed. Is about having a strategy whereby we engage people that are affected with TB, that are using the experiences, networks. We have to capacity build networks to assist in terms of mental assessment of our TB clients, because sometimes in some countries, like in our region, in sub-Saharan African regions like Kenya, we have very few healthcare workers or very few psychologists. So that means that every time the system in public health, they will tell you that we don't have enough human resource. But we have networks of people that are affected with the diseases. Like now we have network of TB champions. In India, I know we have people that are having organization of people that are affected with TB. Why can't we empower them? Why can't we do capacity building on them to assist in assessing and supporting the component of mental health when it comes to tuberculosis? That should be part of the package, whereby if somebody starts TB treatment, they go through the hands of a psychologist, not necessarily a very professional psychologist in terms of somebody that is a full psychologist, but these skills can be cascaded to the network, civil society, people that are affected with TB support groups, so that a support group is not just discussing side effects only. We discuss even issues to do with mental health and also screening mental health. It's not about going to a psychologist, but it's about a basic, a very simple screening. How do you feel? How do you feel when you start taking treatment? How do you perceive this treatment? Those few things, those just those simple things that we ignore are those that make up mental health when it comes to TB. So we can engage TB affected communities by empowering them, building their skills to assist the system. Because if the system has less of human resource, this community can take over and support those components. And then when we as communities identify that this person, maybe their issue of mental health needs a higher level of management, then that's where we can bring in a professional psychologist or a professional mental health doctor to that level. But basic one, it needs to be part of package of care, and let's build capacity of the many TB affected communities that are there and are able to share their experience and support people that are on TB treatment, walk this journey. It's about walking the journey together. Maybe the doctors are very busy, they don't have that time. Like Ashna said, in private facilities, maybe they focus on the doctor's time. So why can't we now engage communities and ensure that our communities through the network, support groups, community affected with TB, they are able to take up that responsibility, but they need to be supported, given resources and capacity build every now and then, so that they are able to assist and reduce these issues of mental health. If we handle it at a grassroots level, we will not have even incidences whereby they need to escalate to that higher level, because we'll be able to respond to very basic things before they trigger and before they mount and become a huge problem in terms of mental health and TB.
Thank you, Stephen. I'm going to take some of the points that you made to actually Dr. Karima. Dr. Karima, I really wanted to bring you into this discussion because you're a mental health specialist. You understand the comorbidity that we are talking about in significant detail. Looking at the experiences in Indonesia, but also your understanding of mental health, how feasible is this to provide mental health? And what would be the key areas that we should be working on from an expert perspective?
Yeah, thank you very much for inviting me here. Before I started to explain what I've been doing with the TB team, I'm working at a provincial government hospital. So this is the highest hospital, the referral hospital in East Indonesia. And I've been working with TB team in my hospital since 2019. So I just started to join them in the last 4 years. So I think before we talking about the program, the involvement of psychiatry into the TB team is just only in a few years. So it means that the awareness of our colleagues who working in TB issue, maybe in Indonesia, maybe a little bit late involving us into their team. In the past 4 years, we've been done, I think I agree with all panelists that initial assessment of mental health condition is very important before starting the TB regimen. So we start with mental assessment for all patients who has been programmed for initial treatment in our hospital. And we have a guideline for patient TB, especially for resistant treatment TB, that all patients have to be assessed with a psychologist or a psychiatrist. And in the last 4 years, our colleagues from pulmonologists, internists, and I think any other surgery who works with TB, they seems like they get the benefit from our involvement into their team, because they can prevent the non-adherence patient. The issue about non-adherence is very high in Indonesia, and they involve us more. And now in the last 2 years, they involve us in a community service. So this is I think this is a bless for us, because mostly psychiatrist is known to treat the crazy people, and now we come in the next level. We involve into the physical and mental comorbidity. So in the last few years, we collaborate with Ministry of Health, and we collaborate with Provincial Division of Health. We train the volunteers, we train the primary cares, health workers, and now our ministry has been revising the guideline for patient with TB, and they involve us into the revision of the guideline. So I think this is a very enlightening for Indonesian, because Indonesia only has 1,200 psychiatrists and less than 1,000 clinical psychologists for 3 million people. So I think community service and empowering people around TB programs will be the most important and the most visible program to overcoming the mental issue. And I agree with Ashna and Prasi that talking about the poverty. Several months ago, I've been doing a focus group discussion for the patient who has already become the alumni of TB patient. And the two issues, the most important two issues that been reported by them is, the first is the financial issues, and the second is the mental adverse effect, psychological adverse effect from the TB regimen. So I think in Indonesia, this is a small portrait from our community, TB community, that poverty and the psychological adverse effect must be anticipated, must be managed since the started of the regimen itself.
Dr. Karima, I want to ask you a question, but I'll request you to answer it very briefly. What is the reach of this mental health services in the private sector, in your experience, in your country?
Yeah, I think most of them has not the ability and the confidence to surviving in mental health. So I think the capacity building, not only giving the skill, but also supervising from to the community is very important by the expert, psychologists or psychiatrists, so they can have the confidence to do psychological assistance, counseling, or maybe empowering the society.
Yeah, I think these are important points. I'm actually concerned also because, and I'm going to take that question to Prachi and Anita, because while we know that the public sector does often what we ask them and advocate them to do, in countries, many of which are high burden countries, the private sector has a very critical role to play. And apart from capacity, there is also the lack of investment that happens in providing mental health services to TB affected individuals. So I want to both of you to answer it very, very briefly. What are the challenges in the private sector, or how would one get the private sector to participate? Anita, would you like to go first?
Sure. I think that, I want to echo some of the points that have already been raised by the other panelists. I think what I would add is that I think it's really important to promote the evidence base on the value in integrating mental health with TB, because often the private sector does have more resources than the public sector. And so then it really just becomes about the stakeholder buy-in to want to do it. So that's one. And then, as you had said earlier, even if they want to do it, sometimes they don't know how. And so then the second thing is also about the steps into how you can do it in a cost-effective, feasible manner that doesn't burden the existing health system, but also provides that value to the patient. So I think what we've also seen in our experience is often the middle management or the decision makers where it goes and get stuck. So the sensitization around what is mental health? How do you look out for it? How do you integrate it? Look at what the evidence is saying. The guidelines are available. Just follow these.
That's an interesting sort of example. Prachi, what do you think you have some experience with the private sector, working with them. How do we activate or engage them?
So see, obviously everyone knows that the private sector's inherent DNA is profit making. That is there. So when we talk about TB or any other program, we need to, and this is our experience because we launched the first program with the private sector for TB in India. There was this PPIA model where we actually acted as an interface agency between the private sector, the standalone private sector, the small clinics and hospitals and pharmacies and pathology labs, and then the government on the other side. So we acted as a bridge between the two and brought them together. So I would carry that experience with me, because I think that was a fabulous model where you are not disrupting the market. It is very important when you work with the private sector, whether it's a very informal provider, not trained, legally not allowed to provide treatment in the village, but still first point of contact for all the villagers for any kind of health crisis, to super specialist doctors in hospitals in big metro cities. So I think the main charm is that you do not disrupt the market. Without disrupting the market, you will have to construct ways and mechanisms to engage with them. And I think the fabulous model that we did was that instead of we did engage all the private providers ranging from the doctors, pathology labs, and pharmacists. But when you talk about doctors especially, so doctors are very expensive resources. So why do you want a doctor to be providing those services which a counselor or a lay person who's trained can easily provide? And as I said, that majority of the cases, TB patients also, they suffer from mild mental health issues. So it's not that everyone is like very moderate to severe category. Yes, they will be moderate, but severe will only be 2-3%. So when you're looking at something which is so huge, you don't need the doctor. So what we did was we engaged the doctor, but we doubly engaged with their assistants, with the compounders, as we call it in India, but there'll be assistants otherwhere in other places. So we engaged with them, we sensitized them, and of course, there was incentive for them to notify patients, to counsel patients, to register patients. And I think this is very, very important, because when you look at public and private, you will need, whether it's TB, mental health, or any other, you would definitely need an alignment from both the sectors. And I think that one is obviously the development sector, and I can hear everyone, and I concur with all of you, because what I am saying, you know, and what you are saying, I know. So, and momentum has already been built around mental health, not just limited to TB, but across everywhere. So the only thing that we need to, you will have to attract and tempt the private sector, and they will gradually do whatever you tell them. But there has to be adequate profit for them. They see that whether it could be incentives or there could be increased footfalls, whatever it is. And so I think the government approach of the public-private mix is something that is really working. Of course, there are challenges related to it, but I think this is a very good approach that if we tighten some loose ends, this is going to produce a lot of result, even in mental health, if we decentralize and activate all the community structures, ensure that capacity building, orientation, awareness, and empowering the patients and family is done. I think this is very doable, and our experience definitely tells us.
No, thank you, Prachi. We are almost out of time, so I'm going to actually start with Stephen and ask a simple question, and all of you have a minute to answer, or more, hopefully, since this is turning into this has been a very interesting discussion. I want to give everybody the opportunity to respond. One gap, one challenge that you think needs to be addressed, and some key takeaway that you want to stress on. Stephen, over to you first.
So, thank you very much, Apal. Number one, I think it's about systems. We need to strengthen our systems. Number two, we need to have policies, bold policies that include mental health into TB. And when I talk about integration, it's not about getting new people to come and start engaging our TB client, but empowering and capacity building the current people that are offering TB services. Remember, a TB client every time will trust the person that usually gives them treatment. But when you now take them another place, they will feel like now you've exposed them. So it's about empowering and capacity building the people that we have, especially communities that are affected with TB, to offer these services. And finally, skipping to the promise. And when I talk about skipping to the promise, is about when we say that treatment is going to be offered for 6 months, somebody will have to come this day and take treatment. They should not miss any day missing their drugs. That means if I come to a facility, I'm coming to pick medication, I should be given the enough medication as agreed, not about being given half and half. Another thing is about managing side effects. If I come to the facility and my side effects are not addressed, then I'll go down, I'll go with stress, and I'll start having mental health problems. And then finally, it's about linkage, correct linkages. It's not a linkage of word of mouth that go there and there. Let us make systems to work to ensure that if I'm linked from point A to point B to assess a service, I'm not just left there to struggle alone. I'm walked through the journey up to the relevant place where I can get and access that service. And it should be a service quality, better quality of service, and a service that is adhering to human rights principles. Thank you.
Thanks, Stephen. Ashna, we've heard client, we've heard health system strengthening, we've heard policy.
I'm going to speak to behavior and narrative change, actually. So one of the things that we constantly hear around TB and COVID, and really even cancer, is this very military metaphor of war and battle and champions and all of that. Excuse my language show, but this really gets me. Like, it's just hogwash, because what you're really telling someone who didn't survive is that they lost, or is this like a sport? And there's a lot of shaming around it, like, oh, they fought bravely. That at some point you've got to stop making it about, it's not the Hunger Games for patients, right? We're all going through illnesses, we're all going through a certain condition, we all have different limitations and different strengths, and those come in, and a lot of it is just privilege and luck. I mean, I didn't survive because I'm special. I survived because I had enough money, enough knowledge, and enough access to people who could help me survive. And sure, there was some amount of my contribution also in terms of taking my meds and whatever, but that's minuscule compared to the rest of it. Take all of the rest of it away and my willpower alone wouldn't help. So this language around willpower and just push through it, and this extreme sports language really needs to go. And the second is behavior change at the level of this othering of mental health needs to stop. If someone is diabetic, you don't tell them just will yourself to produce more insulin, think positive thoughts. No, you tell them to take insulin, you tell them to make lifestyle changes. But with mental health, it's 2023 and we hear some bizarre things like think positive. You have everything. Why do you have depression? I mean, imagine using that logic for anything else. You have everything. Why do you have cancer? Why do you have TB? Why do you have HIV? So it kind of doesn't work that way. So these fundamental shifts sort of need to happen while we're looking at all of the other stuff as well, because this stuff often goes unnoticed. Words matter, language matters. The baggage that we carry around these things matter, and it really affects patients, because I've seen patients guilt themselves that I'm not trying hard enough, or maybe, I'm just not strong enough, and this ableist garbage really just needs to go. So yeah, thank you.
So thank you, Ashna. Ableist garbage needs to go. This is not the Olympics, nor is this, one should be shamed into saying things that one is going through. Dr. Karima, I want to turn to you. Any gaps, challenges that you think really need to be addressed immediately?
Yeah, I think in Indonesia, we need to two words, collaboration and integration. Because when we work alone, we cannot meet in the middle. So I think raising awareness to all sectors and asking their collaboration in integrative way and continuity care, there will be a problem solving for TB in Indonesia and to all the world. Thank you.
Yeah, no, I think that's really important, critical, that systems are linked and they collaborate. Prachi, can I get your inputs on this?
So I have a very different input to add here, because I will not comment on what all of us have already mentioned and about the system and collaboration, partnership and stigma and everything. But what I think is that I do agree with Ashna that the narrative has to change. And this is not going to happen now or anytime soon. This is something which will pass on from generation to generation. So I am looking at something which is more relatable, which has to start early on in all of our lives. So my kid who's going to a nursery class or even class 1, it should start from school education. This is something where, because mental health, we all have realized it has been there always, but COVID has actually brought it out in the limelight. So it is getting the due recognition. Otherwise, early on, people used to say, "Arey, wo paglo ka doctor hai." It's like he is a doctor of crazy people or some such. But now there's been this respect and people have started acknowledging. So this is something that I would say that there's a huge gap where from the school education side, we must start emphasizing on what mental health is, how and what words or where you are looking at. How can it impact to kids who are going to very good schools and receiving good education, and also to kids who are going to, say, village-based schools, informal schools. So I think this is something that we need to start kind of focusing on, because otherwise, other than that, you know that there are a lot of gaps within the health system. You know that coordination between, say, health ministry, there is a national department for TB elimination. There's a program for national mental health program, but they don't talk. So even if they talk, there's a lot of talk going on. There's a lot of discussion going on, but there's nothing which has resulted into doing of things. So there's no integration. And apart from that, there's stigma, there's a lot of human resource crunch everywhere related to doctors or to even the lay workers and volunteers. But I think the key thing now for us to focus is education. Awareness is something that we need to build momentum on. Thank you.
Thank you. That's very well said, because neither should mental health be a privilege, nor should it be a burden. The normalization of it has to start. Otherwise, you can't really talk about it. Anita, what about you? Key challenges, gaps, very briefly, that you think need to be brought forth, addressed?
I think what I would add is that I think for both TB and mental health, care, it tends to be at the tertiary level. And so for me, an important gap is decentralization. It really needs to go down to the community level, both for TB as well as for mental health, and thinking through what those decentralized community-based models that are scalable can be, because I think that is a fundamental gap. That's where the community is. That's where the challenges are. That's where the people are. As Ashta said, very few people actually make it to the tertiary care, quality care that they need. So decentralization would be my my recommendation.
No, that's very, very, very important and very helpful, because often all this conversation is based in and out of urban centers, and we forget the state that a lot of the layers are. And that brings us to our last speaker, Shelja. This is perfect, because I know you work at the grassroots. I know you work with populations that are not just at high risk, but often existing in social and economic systems, which make them vulnerable. Any key gaps and challenges that you think need to be urgently addressed or highlighted to bring this to the fore?
Thank you so much. So I actually completely echo with my co-panelists, but I'll just add this, we need to work on resilience building. So when we talk on, addressing the mental health issues, once it's been identified, screening, it's completely important. It's very important. But what is also important, like we need to stop developing, where they are able to cope up with the issues at the individual level. So the resilience building is somewhere we are also working somewhere on that line. Now we have started working on. So that is somewhere we need to start, and it can be on the part of the resources, which can be on the low cost, where you can just have IVRS sessions which can be done, or some of the mindfulness activities which can be planned. But yeah, this is something which needs to be, that can be done. Yeah.
So I'm going to start, because I think the organizer are going to ask me to shut up any minute now. So I'll shut up myself rather quickly. I think some very interesting points have been brought forth by this discussion. We've talked about the lived experiences. We've talked about the individual experience. We've talked about the community-based resources that we are not utilizing currently. We are looking at task shifting. We are looking at policy, programmatic support, but most importantly, I think we're looking at the fact that there is a great deal of momentum around and conversation around TB and mental health at this point, and there are enough examples to work from. The idea is who is looking at them, who is looking at the evidence, creating policy and programs that can actually support those affected both in the public but also in the private sector. I don't think it's going to be done even in the next year or 2 years or 5 years, but it will be a conversation that has started, and that's something that we have to continue, because each of these is a task that has to happen simultaneously, and the change will then happen kind of over a period of time. But particularly, I think I want to highlight that mental health and TB are so deeply interlinked that the conversation has to go down right to the grassroots. It has to permeate very often from where we start, whether it is medical education, health system strengthening, training, capacity building of individuals, but right at the grassroots and move upwards. Because very often, one of the things that we found is that policy is great, but its implementation is not so spectacular. And people who are often at the highest risk remain vulnerable and remain at the periphery. So with that, I'm going to end my conversation around this. Joel, I'm handing it over to you. Please let me know if you'd like to take this forward and have something to add.
Thank you so much, Chapal, and thank you all the panelists for bringing out such important points. I know this topic is not something easy or to discuss as well, but it is quite a vulnerable topic, and all of you were so amazing in sharing your thoughts. So thank you so much for sharing these views, and thank you participants for joining today. And we had a wonderful chat going on, which was also important. So just to clarify, we have started an online forum discussion on this topic. So if you want to continue this conversation, please visit the TBPPM Learning Network. I'm dropping in the link in the chat. So feel free to add in your thoughts on the topic today. And thank you, Chapal, for wonderful moderation and keeping us on time. We did start a bit late, so glad that you were able to wrap us on time. So thank you all, and I will send the link to join the Learning Network as well. I invite you all, if you're not part of the Learning Network, please do join the Learning Network, and we will keep you updated about upcoming events and upcoming Friday forums. Thank you, and have a great rest of the day.